We're working. There's so far no showstoppers, issues here and there, but nothing that's cause for panic. Yeah.
Laura, you can hear us? Laura, you can hear us?
Yes, I can hear you.
Okay, only people who are in the room can present anyway. Can we get started? Seriously, it's 10:09. There's guests. They can, just whoever needs to be here is here. Dash, please.
Yeah, while that's happening, I'll. Who's
Angela,
first?
let's start. Can you pull out the
Yeah, well, where is it?
Can you just move it? It's distracting having. Okay. Well, let's say we're ready for you. Oh, sorry about the delay. Good morning, everyone.
Nice day.
Nice to have you here.
I know. Who's on the?
Oh, thank you. Who's on the phone? Do you know?
We have Laura who's sick, so she's remote.
And Kathleen, was Kathy gonna be on the phone? Someone said she was.
No, she's not in this committee.
Okay, I didn't think so. I think she's in the audit committee, right?
Yes.
Okay, so why don't we start with opening up the meeting? And the first item is the minutes. Anybody have any questions, issues with the minutes?
No.
Nope. Can I have a motion to approve the minutes?
Second.
Great, thank you. All in favor?
Yes.
All right, our first item on the agenda is Project Edge.
My name is Tamash, and I have the privilege of presenting you an update about Project Edge. I'm not going to talk about status like I did during the last few board meetings, but I want to tell you about our upcoming go live on December 15th. We're deep into our cutover activities, which started about a week ago. We are live on one of our two systems. Guiding Care has been live for a couple of days now. We've processed 45 new authorizations in the system, continued 274 from the legacy one. And while we've seen some small minor hiccups, nothing that would have us cause stress or panic. Now, just to talk a little bit about the magnitude of the go live. This project has been underway from Metro Plus as a concept to an initiative to a program to a large scale implementation for 3 years now. All in all, we've got over 200,000 hours of time from Metro Plus resources from our partners, from the organization to make this a reality. It is no small feat. We designed the system, we configured the system for use across all of our lines of business. We launched Snip first. We tested it in and out. Over 8,000 test cases, over 1,500 defects found and fixed throughout the process. And we're continuing our cutover with a go live on Monday. Just so you get an idea of magnitude of what we're talking about here, we've got over 99,000 practitioners in our system today. And every single one of them will be able to submit a claim and expect payment as early as next week. Now, this journey wasn't easy. It was in fact very challenging. There were many roadblocks on the way. The change to our sequence of lines of business, changes of how we executed and put Metro Plus leaders in domain leadership roles fairly recently. A change to how we approach billing. In fact, we moved away from using the HRP billing solution recently and decided to maintain our legacy solution. But the accomplishment of the go live is a tremendous feat of the team that has made this a reality and priority for the organization, and continued support from all the leaders and executives. Just one more number for you. I asked my colleagues in finance to run a report of how many full-time resources in Metro Plus do we have dedicating their time to this program. As of the month of November, we had 74 people who dedicated more than half their time to an aspect of this project, be it developing training materials and training, be it working on the technology components, be it performing a user acceptance testing that time. So a tremendous achievement from organization to make this.
And it's a serious understatement, by the way. Because in reality, it's probably more like 200 or 250 people. We just don't, we don't report, right? I'm involved in this all the time. I don't count, right? There's just so many people who are actually involved. The reporting, right, for accounting purposes needs to be, conservative, but in reality, I mean, we're talking about massive transformation. That's exactly what we're talking about. It's when Tomas just started talking while I was pouring my coffee, I literally had goosebumps. Yes, it's big. It's the biggest thing this company has done. So it's step one. There's much more to follow. But the 0 to 1 is always so challenging for those of us who've done startups, right? The something from nothing is the hardest step. So although it's a small line of business and we have larger line, but the nothing to something is the most challenging part. And Ganesh and Lila and Tomas and so many others. I mean, literally day and night of pushing it. So I'm really proud of this team.
One of the things I was telling Talia the other couple, I think it was like 2 weeks ago, I was driving on the Van Wyck and I was reminiscing that since I've come to this country in 1981, Van Wyck's been under construction.
Welcome to New York.
Yeah, and it's been, so as you're driving, because they're constantly doing things that of an existing system, right? And so it reminded me of this project. And I was saying to Talia that if we were to start from scratch with nothing, we probably would have advanced much quicker than the retrofitting and getting the data from 35 years of legacy data and information and system to be able to modernize it. And so, riding on the Van Wyck was reminiscent of this project.
And I was thinking when you were speaking that sometimes transitions are harder than the initial startup from it. I mean, it's painful with the transition. I'm even excited and I didn't even work on it. I can't wait to see how it works. So, yeah.
We are all very excited. What's important here is not just the technology transformation, right? We trained over 340 people. Lila and the business operations team has been working on policies and procedures and how to actually use the system for months. It is genuinely, the whole organization was involved in making this a reality and only possible because of the commitment of
Can I ask you a quick question?
Of course.
Forgive me, because everyone probably knows this. Is it just for billing, or is it an EMR also, or an EHR also?
Sure, I think it's a very good question. So our edge transformation spans our core system. So our clinical care management platform, our clinical documentation platforms, as well as our claims.
Everything.
Everything.
So all the
Billing,
providers,
eligibility,
people seeing patients,
contracts,
everyone's gonna have a new system.
adjudication.
Yeah,
It's on the plan side. It's not on the provider side.
got it. Okay, right.
So,
Right.
but all of the mechanics that the plan has
Yeah.
on the medical management side, so case management, as well as billing, payment, financial reporting, eligibility, contracting, adjudication, direct payments from the state to the providers, VBP, MCOR, which is the financial required reporting into the state, all of it.
Wow.
And
All
so
of
to add to that, while it includes all of it, what we've had to do in transitioning to this project, because it is so complex, is Health Edge wouldn't have been able to implement the billing and the MCOR components directly in their system at this moment. So what we've done is we've taken that back into Metro Plus. We have an existing system and we're expanding that out until, so that we can go live while everything is stable, and then Health Edge can continue to develop it. So the billing, that we did pull back the billing into Metro Plus and the MCOR into Metro Plus.
Got it.
I think what we realize, we're quick to judge ourselves, and thinking what's out there, what's in the world is better, more advanced. But we discovered that as it relates to billing, we built a pretty amazing system actually that addresses all of the very complex needs that New York State, thank you very much, created.
Yeah.
And so when a vendor, even a sophisticated and experienced vendor, comes into New York and realizes what it takes to build an entire billing system that will be compliant with all of the New York regulations, it becomes overwhelming and very time consuming. So we actually, that piece lives outside of the rest of the core system, the billing. It's a different vendor, it's a different process. So we realized that what we built with this other vendor around billing is actually very good and advanced and meets all of the regulatory requirements. So we said, well, instead of banging our head against the wall and trying to recreate something that is extremely, extremely complex, we'll keep this piece and we'll just plug it into the new system. And so that was, I think, a really important strategic decisions. We were wavering between keeping, not, there's this utopian vision that we had when we just started, which is we want everything in one place. That was the original thinking. And then as we started implementing, we realized the magnitude and the complexity. So we did carve out Medicare and QHP to go to another vendor, and we decided to keep our billing system because it works and it's good.
Is there a plan to transition the billing? Because I know initially when it started, part of the desire was to go to a more contemporary billing system.
Yes.
Because you have been running on your legacy system for so long. And so is there a plan for
There
transitioning
is.
that?
There is. Only that the billing system that we have is not as archaic as the claims adjudication system. Those are two separate vendors. So the billing system is actually from the century. So it's
actually in-house developed. It's a .NET, a modern application for the billing.
Okay.
Yeah. But eventually we will, as they're
right.
able to develop and it can meet the requirements of the state, then we'll transition. But with the timing, there was no way that they would be able to develop the billing with the nuances of New York State. And so since it's in-house developed, the original billing system called Medibill, and we have the support model in place already, and the team, one of the people in finance made a comment as we were going through this evaluation and then building out that if there was a modification to something, the in-house app dev team would be able to make that modification within 2 weeks. And Health Edge was taking multiple months to make this similar modification. So we realized the time was not on our side. And so let's continue, plug it in, and then we'll continue.
ultimately, yes, when it's ready.
There's a delineation between the billing and the claims adjudication?
Yes.
Because I always
Yes.
saw them as one
No,
thing.
they're separate.
Okay.
They're separate.
If we can go to the third slide, Angela, I want to talk a little bit about what's next. I mean, I think you heard about our go live, and actually we expect to be live on January. We will be live January 15th. What comes after a go live like this is always stabilization. There is always items you discover post go live. We have a command center that we stood up a couple weeks ago to support us through the stabilization process. We see a semblance of that continuing for the first 2 months. We are going to have daily report outs of metrics of how are we processing in the new systems, what are the issues, what are the challenges, what are the deltas, and have a team that prioritizes those, analyzes those, and drives expeditious resolution to any item that is seen as an issue. So this always happens in a system of this magnitude, and what's important, it's not whether or not you find issues post go live, but do you find them first, or do you let your clients and customers find them? Our strategy is to monitor daily and closely so we find them first. And do you have a response plan to address them before they cause a significant adverse impact? And that we do as well. So we're going to stabilize as quickly as humanly possible. I see that about 2 months. The next step will be for us to roll this out across a broader set of populations. Next, we're going to move and go live with our Medicaid and heart populations. We're going to basically multiply the volume of lives on the system 100-fold. We've got what, 4,900 STIP members. We've got around 400,000 lives under Medicaid and HARP that we cover. It's going to be a challenge in that we're going to scale to a significant volume. Also, for wave one, we had a number of processes that we developed quickly that have a manual touch, or they have a potential contingency. We really have to automate all of those processes as we scale volume on it. So wave two will be a next big challenge, but again, we've built out the foundation, and building out the foundation is the biggest block. Now,
When you talk about the next phase, how much of the new infrastructure that you've created lends itself to taking in Medicaid and the absolute numbers, just the absolute numbers, 400,000. To handle that in the timeframe that we're projecting?
Yeah, so about 80% of the configuration is going to be carried over, right? So it's not a rebuilding. So there's a delta of about 20% plus. What Tomas was saying was there are certain things where we took a step back and we compromised, if you will, for phase one. So there are certain things where we've done a manual workaround to say, okay, for us to go live, while we would love to have it automated all the way through, we don't have the time in order to do that. We would need additional time. So there are certain things where medical management has, because it's such a small population, they said, okay, we're going to do some manual steps for now. But with wave two, it's the building out the remaining 20% plus automating all those things that we compromised on.
If you think about it from a numbers perspective, and I'm a numbers guy, we've got maybe almost 2,000 requirements, 1,900 and some odd. Wave one and wave two. Wave two is approximately 200 of unique requirements to wave two. So I think Ganesh's point, 10% is net new requirements, another 10% of that automation. From a scope perspective, it's significant, but it's not in the same order of magnitude as wave one was. But you do have to test it across a much larger volume population set of scenarios that don't come up that often. So it's not a trivial undertaking.
I'm still stuck. I'm still thinking about the claim system. The adjudication of the claims is with Project Edge, or
Yes.
Okay, so you've had to link those two as part of that.
Yeah.
Okay.
The one more item that I want to
It's a big
mention,
challenge.
and you hear more about this from Ganesh soon, is that we've reached an agreement with SS&C for them to continue providing us services in 2027. And that is a very major item for us in Project Edge. Our original plans were to go live with all of the remaining lines of business in 2026. It would have been a sprint for each line of business, and we would have been pursuing minimal viable product each and every time to make that timeline a reality. That, how they calls it, insurance product, that insurance, that additional time enables us to do wave two and wave three, our BPAS agreement right. It enables us to pursue automation where it's necessary. It enables us to get the maximum value out of the solution the first time around to do it. So when we think about what's next after Medicaid and HARP, we also have to get the MA and QHP business done in 2026 to our new partner Wipro. Again, it's very important to do that around open enrollment. So you enroll the members in a new platform. You don't have to move them between systems and bits and pieces. So what to look from us as Project Edge in 26 is to go live for the Medicaid and HARP populations. Again, increasing volume on the platform 100-fold, as well as executing on our partnership with Wipro and implementing a solution for our MA and QHP lines of business around open enrollment next year. And we're going to take advantage of the extension with SS&C to do wave three, our commercial population and EP right. And we're looking at that as a 27 goal.
If you put in EP with Medicaid, notwithstanding the similarities?
Yes, and there's a couple of reasons for that. There are a couple of reasons to it tied to the fact that EP does have a lot of similarities. It also has a lot of differences. There was also a lot of uncertainty of what EP was going to look like earlier on in the year. And when we did our requirements and planning, it'd be difficult to redo it as we were expecting some of that guidance. So some of that was done as how do we do this thoughtfully and meaningfully and get all the functionality and minimize risk and avoid rework, right? We really want to avoid rework as much as possible.
Right, it's still unclear exactly what's going, I mean, we know EP5 is gonna peel off in July, right? Then we hear, well, we know that cost sharing is coming back for the other tiers. It is not clear what other changes the state may propose. They're still thinking, as far as we know, about, well, what to do with those people who will be uninsured. Maybe they will be plugged in somewhere else. Maybe the state will be sponsoring some what is it? Not credits, subsidies, the subsidies. So there's just a lot in flux and unclear, and the state updates us very, very late in the process. I mean, as it is, we're building a new plane while flying the old one, but building a new plane while the design is changing, I mean, that is really too much.
Sorry, EP stands for
Our
Essential plan.
essential plan. Okay.
So it's a step above Medicaid, both in terms of income eligibility, but also EP caters to individuals who are in different legal status in the country.
Got it.
I'm Medicare, at one time you had said you were gonna keep, that was gonna stay outside of
So at first,
Project Edge.
yeah, so at first
So-
we were gonna bring it in.
Right, and
Then
then
we
you
saw,
just-
then we said we're gonna bring it out. So we are bringing it out. So that's when it says BPAS and Wipro is our vendor that we're gonna work with for the, to
So
have it.
that's just the integration. It's still gonna stay outside, but
It's gonna
you're
stay-
linking
correct.
into their
It's gonna-
system so
They're
that.
gonna use our health edge system,
I
but it's gonna
see.
be managed by a
By
different
them.
company called Wipro.
And what's the benefit of that?
It's cost effective right now, as it stands, but we don't have the skill set for the processing of claims for Medicare and QHP, and so they're gonna be processing it. It's one of two things. Either they could host it themselves and be completely independent of us, but then for reporting, we would have to build another system to then pull in, all the reporting that we need. So the other model is to use an existing health edge system as just like we're right now, when we're using PowerStep, we're using PowerStep, the mainframe, and SS&C is using the same power for us, but it's in the same underlying system. So we have full access to the data.
So that you can integrate.
Yeah.
Okay. So it's outside, but you're linking in so
Correct.
that you
Yeah.
can manage.
Yeah, I think that's correct.
It's just a little confusing when you have it on the Project Edge timeframe of understanding exactly what that means.
Yeah.
It's just, and I know you know this better than us, Valencia, but Medicare is its own beast. And there's a reason why in the call center, we have a Medicare group. There's a reason why in we have Medicare group. There's a reason why in ICM, we have Medicare group, because it is its own beast and it requires disproportionate support. And so no other line of business, and Medicare is small for us. Nevertheless, in each of those areas, I don't know if claims has also a Medicare. I think, yes. Yeah, claims also has. My point is, it is a different species, completely different species, and we treat it as such. This is why there is a Medicare unit within each of the units to build the expertise and build the technology, and now have that on, with Health Edge, was going to delay us in a very significant manner. Also, right now, because we know how it works, because we have the dedicated teams in Medicare in all of those areas, it's also expensive. It's expensive because you have to staff it in a way that you're fully compliant with all of the CMS regulations. If you have a small population, the cost effectiveness of it does not work. So for those reasons, and because we have experience of how, I don't want to say babysitting, but how particular we are with managing Medicare in the different areas, it became very clear to us that we cannot create this cocoon within this whole new system. We need somebody else. in the future, will it make sense to, and we continue to grow in Medicare, we're doing quite well. Will we bring this in? Yeah, it's not as massive implementation as what we're doing. It's big. It's not trivial by any stretch of imagination, but differently from Health Edge, if we decided in 3 to 5 years that we're big enough, it makes sense to create this Medicare cocoon here, we could bring it in.
Yeah, and what will be great about us using the existing Health Edge platform at that point, if we decide to, the data will still be there. It'll be in our system. And so we'll just now have to transition the actual working, the claims processing piece, the resources, the people to do it internally. So it'll make it a lot easier in the future.
And also just risk mitigation, right? We and everybody else, this is not Metro Plus special. There's a lot of risk involved in doing what we're doing. A lot. Regulatory, reputational, financial, operational. As we started doing it, and you've been with us through this journey, I mean, although we knew, we went into this with our eyes wide open, when you actually start implementing it, you feel it. You really feel it. You know how bumpy it is. We had to de-risk the implementation.
Yeah, I understand. Is that your last slide, Thomas? Okay.
Yes, thank you.
Okay. Good morning. So as Tomas was alluding to, right, this is a major project. And so one of the ways to de-risk our ability to get this done was one of the driving factors of the timelines that we had was dependent on our expiration of our SS&C contract. It was originally expected to expire December 31st of 2026. Therefore, that drove all of the decisions, the rush, the compromises, as opposed to a more robust program where we, instead of just concentrating on MVP, the minimal viable product, we can concentrate now on a fully fledged product with a lot of the automations that we were seeking initially. So we've decided to take this quote unquote insurance policy, if you will, to extend with SS&C until December 31st, 2027. Will we take full advantage of the full aspect of 2027? Maybe not. We don't know yet, but at least that's there. And in order to accomplish that, what we had to do was purchase, because they were going to sunset PowerStep in 2026 and CareConnect in 2026 with no ability for us to extend whatsoever. We had to take a strategic decision to purchase the source code. And with that purchase, they've also included in there the hosting for us. So normally if we first declined to purchase the software because you'd have to take it, find another mainframe system, do another implementation. So we said no. But when Talia was able to negotiate with them to say, okay, if we purchase the source code from you guys, you have to host it in 26 and 27, offset our normal costs that it would have taken. And so we balanced it by offsetting the hosting maintenance costs that it would have taken. And then we purchased the software. The next slide. And so while we're informing the board, but we're not asking for additional authority because it's the way Talia was able to negotiate this was it is still within the realm of our authority, both from the MetroPlus board and the H&H board to begin with. And so we're just informing the board of our decision to purchase the source code and continue to host it for 26 and 27. But again, on the cost perspective, it's still within our authority that was originally approved by by H&H and the MetroPlus board.
Just a quick question. When you started and projected out the cost of Project Edge, where are we now? I know we've had to see changes for all reasons legitimate and we've gotten approvals, but where are we based on where we thought we'd be originally projected anyway?
On the full health implementation, I think we'd have to get the full financial back to you guys. We are within budget and provided we had some contingency baked in. So within, but to get you more factual, work with finance and get you an exact up to date. We've had a few change orders that we've gone through with them, so we'll get you those numbers.
I mean, the important part, we'll give you the actual number, and I apologize, this is a really good question and we should have presented it. But we are, as Ganesh said, we're still within our spending authority. Because we ate into some of the contingency, will this be enough to last us the full 10 years, right? Because the contingency was spreading over the 10 years of the contract. I don't know right now. We know that we're fine right now, and we're managing it quite well, and the addition that we're paying for the source code is offset by some of the licensing fees we would have paid in 2026, right? Because we were planned on, staying with SSNC, because we still have to fly the plane while we're building the new one. So we're not paying licensing fees because we bought the source code, and it kicks in January of 2026. So there is some offset. It's not net new spend.
So like the $15 million for new personnel. Is that part of the larger budget? Do we add that to the total budget we were projecting? Or is that?
I don't remember, isn't
So Metro
the
Plus,
capex or
the
not?
Metro Plus temporary employees for the continue. So what we're gonna offset is some of the management consulting services that we purchased, like with Accenture. We're going to we're not going to renew them. We're gonna have that. It was originally projected that we were going to have a resource funding that we did not actually use in 2025. We're moving it to 2026 because that projection, and I forget the exact number, but if you say it's like a 50 million, that was originally from 25 that we've not dipped into, and we're moving it into 26. But we're offsetting that by, again, not going through the management services consultant. So we'll,
Great, Roger, you're up next.
Okay. So membership remains strong, and the decline has neutralized and now stable with a slight increase in November and December. EP and Medicaid managed care has no market share change. We kept the same market share. CHIP and HARP had a slight decrease by 1% in their market share, and Medicare increased by 0.5%. PIC had the greatest gain. It went from 24% to 27%. So we had a big gain there. You had asked me at the briefing what our market share of the health and hospital employees for Gold. So of the 45,000 total employees that work for health and hospital, we have 10,483 unique subscribers. So that gives us a 23.3% share of H&H's employees.
Well, Mitch set a new goal for this year, and the goal was 40%? I think it was 40%.
Okay.
So
double it.
There was a very, very strong push by all CEOs across the system to present Gold and educate Gold. Obviously, in the end, people choose what they want to choose, and that's totally fine. That's part of the deal. But we worked very hard with Mitch's support and all of the CEOs, including subacute, including literally everywhere in all the facilities, to make sure that people are aware of what we're offering. So we'll see. We'll know by the end of February?
Yeah.
By the end of February, we'll know.
The effort was very visible, even during the most recent town hall. Mitch spoke to it and gave us some very nice words recommending us to the employees. So there is a concern enough.
For someone who's been around a long time, 23%, when there's a total of 13 options to choose from, and we have 25%, which is a quarter, that's pretty good. I'm still up for the 40.
Yep.
But I just wanted people to remember how many options there are. There's 13 choices.
I'm sorry, is that just the H&H employees?
Yeah.
Or there's also other city employees?
Yeah, so on the other city employee front, there are roughly around 285,000 unique subscribers.
Okay.
When you add their dependents, it's more, but unique subscribers is 285,000. We have close to 9,000. So that's a 3.1% share of the other agencies.
Okay. Yeah.
And again, when January comes and we start seeing the efforts from the fall transfer period, that number should spike.
And so, it's a quarter of all the H&H employees join Metro Plus Gold.
Correct.
And this is your first year, right? Like, or,
It's not our first year, but the biggest push has happened in the last.
So up until 2016, the gold product was only available to H&H. And then in 2016, it was opened up to the rest of the city.
got it.
So it's been open to the rest of the city for a very long time. Not for this public forum, but there are significant headwinds that precluded us from expanding as much as we wanted outside of health and hospitals. They're being worked on persistently, but they're inherent in how things are structured. The other piece that is important is we're an HMO. Most of city employees prefer a PPO.
Right.
So we do not offer a PPO product
Right.
versus in the other options that are available, the most popular product is a PPO.
Right, of course. And the HMO means you must go to H&H for your care?
No, but it means
Who's
that
in the HMO?
it means that you have to have a PCP, right? In an HMO structure, you have to have a PCP who manages your care and refers you for other
Got it.
needs.
Got it.
Versus PPO,
Yeah,
you have direct access.
It's
So
also
that
cost, isn't it? The PPOs are traditionally less expensive than the HMOs.
No, it's the opposite. It's the opposite.
You pay more on a
Yeah,
PPO because you have the choice.
yeah.
And the
Right,
PPO
co-insurance and the deductibles, I thought always were 3%. I know in my choice.
Yeah.
The PPOs were less expensive than the HMO products.
I'm in a PPO, it's much more expensive now. And
Yeah,
in an HMO where I'm restricted to certain providers.
the other huge difference is out of network
Yeah.
benefits.
that's another part.
In an HMO, there is no out of network. Versus in a PPO, there is out of network.
But it could,
It's costly,
Yeah,
but at least there is some coverage. In an HMO, if you decide to go out of network, it's all on you.
Right.
So those are there are other differences, that there are structural differences, but from a customer perspective, those are the two main ones. The PCP assignment versus no PCP assignment, and then the out of network benefit.
What is also of note is that there was a little over 2 years where there was a mandate that people had to choose our competitor. So we had no access to enroll new hires during a certain period of time that lasted a little over 2 years. So.
Sorry, who's the competitor?
Emblem.
Emblem.
Yeah.
And why was there a mandate that you're saying H&H employees had to go to Emblem when they
All
joined?
new hires.
All- Wow.
City.
For the city.
I think that needs to be taken offline.
Okay, sorry.
Okay.
Yeah, it's okay. You tell me when I.
Skipped over Jeffrey.
so Roger, the 3% and the 22%, I had gotten an email that said that we had about 10% of the city's market share overall.
Yeah, so can anybody hear me?
Yeah.
Roger, I had Bing run some numbers for me and Ken double checked them and the numbers came out to about a 10.5% penetration.
So, yeah, let's talk. Bing gave me these 5 minutes ago, the numbers I just reported. So,
Okay, so he
the
reported something different to you than to me, so we just have to validate what's accurate.
what may be the difference is that I was talking unique subscribers. Remember, there's dependents and spouses, so we just have to check. But of the unique.
Yeah, I had asked him
subscribers-
unique as well, and that's what he gave me. So we'll double check Valencia and get back to you
Yeah,
with.
okay.
latest
I mean, it may make sense with 3% of the New York City employees and only 22%. It may level out to 10% when you look at
When you look at
overall.
everything
At
together,
both,
yes.
Yeah, so it
And that's
sounds
probably
like
right.
about
That's about right.
Yeah.
Because we used to be like 4 or 5%, we've been growing. So 10% of the overall sounds about
And
right.
remind me again that the new initiative about enrolling in Metro, that's just for
H&H.
H&H.
Yeah, group 11.
Employees, right, okay.
So we had a mandate for our own employees from about 3 years ago. When the mandate applied to Emblem, believe it or not, it applied to our own employees.
Yeah.
So there was a mandate for Metro Plus employees to enroll with Emblem. When I started, that was just, it was just not something that we thought was acceptable. So it was adjusted. And so we had the mandate for our own employees for about 3 years now. And then now the new mandate is only for Group 11. It's only for managerial. It's not across the board.
Oh.
Only, yeah, only managerial for New York City Health and Hospitals. And that went into effect in July, I believe, of this year. So it just happened.
And Talia, we've increased our provider network, especially the new systems, significantly, adding Memorial Sloan Kettering, adding HSS. It's become a much more competitive platform now.
Yes.
ACP is coming back into the network as of January.
Believe it when I see it.
I know.
It's just, it's true. And what we're seeing, especially around Essential Plan, because there were significant cuts to the base rate, some of the national plans are pushing those cuts to the providers, because we're all receiving lower premiums with the cuts from the state. So what we're seeing is, because the cuts from by the national plans are being pushed to the providers, there are contract terminations that are happening around Essential Plans. So we're seeing some national plans no longer in network in some of the most prominent systems in New York City as of 1/1/26. We, on the other hand, have not touched it. We essentially more or less kept our contract as is, despite the cut in the base rate that came from the state just a few weeks ago. So again, it is positioning us in a pretty competitive manner. It's not our own goal. It's more, generally speaking, it's actually more around Essential Plan, just because there was the cut. So really briefly.
Okay, good morning, everyone. Good morning, Sally. Good morning, Valencia. Very excited to give an update on 3 critical pilots that we've run this year, contrasting from Project Edge, which is the backbone and the transformation of the organization. We're still pushing hard to build out pilots that are going to impact customer experience and ultimately retention. Very excited to share 3-month results. Next slide, please. Yeah. Just as a background, no, you can go to the previous one, just 1 second. Previous.
Oh, the previous one, okay.
Just as a background, what Usher is, member engagement, self-guided application, and it guides new members, Essential Plan and Gold, through some critical steps in the early part of their journey. Next slide, please. A snapshot of what the screens would look like for new members. When they enter, they get a text, and then they go through some of these menu items, which are listed. Starts with, benefits, sign up for your portal, et cetera, and every part of the journey has a call to action. Next slide, please. Okay, so here is the fun stuff that we can get into. Some initial stats as of mid-November for us, and we're in the process of refreshing the data. So we launched this pilot on August 18th, and we have month 1, month 2, month 3 retention data. We're also comparing it to the baselines for Essential Plan and Gold, which are the 2 products that we're running the pilot in for new members. As of month 3 on Essential Plan, we're seeing an 8.5% higher retention. And we believe it's a direct effect of the engagement that members are performing on the application, due to the application, maybe due to the way the user experience is set up. 1 in 3 members are engaging with the application, which is higher than any number we've seen across the board. I don't have the specific statistics because it's not done in a synchronous manner on PCP selection and member portal registration numbers yet. But when we go into Salesforce Marketing Cloud, I'll show you how that has an impact usually on retention numbers. Next slide, please. Okay, now the second pilot we were running was the Gold Concierge. This is specifically for new Gold members. We partner with a company called Sutherland that is supporting us in providing 360 one-stop shop white glove experience for all our new members. We do everything from helping them with their ID card, supporting them with PCP change, and if they need, we'll go ahead and assist them with their appointments. We're doing outbound new member orientations, inbound new member orientations as needed. And what we're seeing is our average handle time has come down significantly because we're becoming more efficient in how we're handling these calls. But also what we're seeing is members, when they're calling, because we've already primed them, on average, they're asking us, we're working through about 3 issues per call, which is higher than what we do on other calls. What this helps with is also that the callbacks and the call volume for future calls goes down, because we're supporting them on other solutions as well. Next slide, please. High level, this is very similar to other areas. The top reasons that members reach us, they want to update their member information, they want to change their PCP, or they're asking about benefits. And some of them, we've handled about 24 appointment assistance calls so far. Just as an FYI, we're not actively publicizing that we are doing appointment assistance. We offer it when they call. Now, if that changes in the future and we add other lines of business, these numbers could change dramatically. Right now, we don't explicitly call that out. And what we are seeing is, next slide, please. We're seeing that currently about 83% of our members have calls handled by a single representative. And while the N numbers for our satisfaction surveys are very low, so we express caution, we still want to share this. This is the highest customer satisfaction and employee rating that we have seen across the board of any type of survey we've conducted. And one thing that we see is there's direct correlation with one call resolution and one person handling all of the issues. We do have a couple modules where our concierge representatives are not yet trained or have access, which is around prior authorization and claims. And working with Ganesh's team, we are opening that access up for them. So in the future, we have hopefully much more higher single person resolution so that they don't have to be transferred to the customer service line. Next slide, please. I will hand over to Laura to just quickly talk about sales. No,
she can't do it remotely.
Okay, so Salesforce Marketing Cloud, as everybody's aware, we undertook a huge transformational activity, marketing, brand, customer experience, medical management, everybody across the board on transitioning all our campaigns from mPulse, which we used to historically have some hiccups with. And we were able to transform that this year. And we went live across all our mPulse campaigns except IVRs as of August. And what we've been able to already realize is it will yield over 800,000 in savings. Where we started as of December was in new member onboarding and recertification campaigns, but where we will, and then what we added was the new Gold Fall Transfer campaign that we launched this year. And we are also starting the lead nurturing process that is targeted for Q1 2026. So we started with retention with our existing members, and we're now expanding to our acquisition part of the journey as well. And now where I'll close out for all of our pilots is just high level how the launches on Salesforce Marketing Cloud onboarding has gone. And you can skip over. You can move to the next slide. You can move to the next slide. Quick snapshot, not going to go through this. When we ran the pilot, we ran about 14 touch points on onboarding. We moved that to 10. This is what you're going to see as of month 4, a 3% higher retention on the full scale rollout compared to the pilot. That's the big kind of takeaway. And the pilot was already higher than the baseline. So we're very excited. This head-to-head is only on Medicaid, obviously, because the pilot was on Medicaid. So we can't compare the other LOBs, but we have launched it in all LOBs except EPN Gold, because that's with Usher, and MLTC, because that's coming in January. And then next slide, please. I just want to point 2 seconds quickly to the actual engagement statistics, which we will eventually see on Usher and Concierge as well. The completed PCP appointments on the full-scale rollout are 36.7%, so about 4% higher than the pilot. So that is already showing us that what we're doing, the number of touch points, et cetera, that we're running is working. And then when you see member portal registrations, massive. We're seeing almost like an 8% higher member portal registration. All in all, this is good news for the direction that we want to go, which is around self-service, 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 bring down call volumes, increase members' access to being able to service whatever they want on their own. Because nobody wakes up every morning and says, hey, I want to talk to my insurance company today. And then on research, next slide, please. No data available yet. The reason for that being, it's a 3-month kind of lead time for us. The first members that we launched will only be ready for research in January, February. So when we come back in February, we'll be able to share research data, which I know is top of mind for everyone as well. And that campaign has been automated entirely. So I know our recertification colleagues and retention colleagues are very excited. So that was the update on the pilots. All in all, great progress, very excited, and huge thank you to our IT and analytics team that have, despite all of the work that's ongoing, still pushed on and made sure that we're doing all of these exciting activities, but very critical activities to continue to work on member retention.
I just want to say, we talk about Health Edge as being transformative, and it is. This is transformative. I mean, when we see, it's so hard to move the needle. So even 1 or 2% on the population we have is massive. It's massive. And we are moving from phone calls and massive kind of manual labor into more automated, on the members' terms, on the members' time, whenever it's convenient outreach, guiding them through the maze that our system is operating in. It's, I look at this every single time, and this is what good approach looks like. You have an idea, you do a pilot, you refine, you launch, you have results. So I know we don't have the research yet, but all the early indicators are extremely, extremely promising. And it's not that we just happened to stumble on something. It was done in a very, very methodical way. And this is why we're seeing the early success we're seeing.
Can I ask a quick question? It seems amazing. Do you ever solicit feedback from actual members in terms of their experience of using the portal? I'm imagining that it's not easy for some folks. It's not easy for people who are used to, using complicated things on computers, but particularly our population, I'm guessing. So just curious about how you get input around what their experience was.
So we have, I don't know how many tools that we use. We do our regular surveys. We do longitudinal surveys. We do member advisory boards that are live in person.
That seems like it would be most, right? Like people actually saying what it was like.
Yeah. Go down. Yeah. Yeah. So we get feedback, and a lot of what's happening is an output of that.
Great. Yeah. Okay. Wonderful. Thank you.
Keep going. Unless you have like very specific areas that you want to focus on, I'm just, I'm trying to help us.
Okay.
Whatever you want to focus on, or do you want me to?
No, I mean, it's hard for me to say because I've already seen everything.
Yeah,
So
yeah,
I've
yeah.
had my questions answered. I don't know if this committee would want to get an overview of that area. Call center.
To look at complaints, that might be an interesting area to.
Yeah, it is interesting. But Ganesh, one question that I have overall, what percentage of the population is on Salesforce? Because I know that we're seeing some very good
Yeah.
results on. the
So
numbers.
I can tell you the latest number, but on the member side, it's about 100 and close to 150,000 registered users. I can get stats on the frequency of their login. I had gotten that stat about maybe 3 months ago, and I think it was about 20 to 30% of the population are continuously logging in. Most of the other ones are one time every few months.
Do you ever filter by age? Like, I'm just curious if your older users have more trouble, and you know if it skews younger.
I can run those numbers. But I know, to Brenda's point, when we had the member advisory committee, actually, there was a young lady, probably in her mid-20s, that indicated that she prefers to speak to a live person. And so no matter what tools we give her, she's going to call because she prefers that actual social
Because I
contact.
would have thought it was just the opposite.
Yeah.
I mean, I want
Yeah.
to people a lot,
Right.
Yeah.
but.
You know, it's young, yeah,
Right.
yeah,
You wouldn't
exactly.
even buy a car by going to the dealer.
Yes.
But it was a,
Perfect.
Yes.
and it was a young person. I was really surprised by that.
Yeah, that is.
Yeah.
surprising.
Interesting.
I have a question about telehealth. This is for another time, but I am curious about the number of folks who use telehealth and the demographics and stuff like that.
We'll bring it, should we bring it to the next committee meeting, or you want to see it ahead?
No, it's fine.
Okay, we'll bring it to, actually, the
I'd be
whole
curious about that
experience.
too.
Yeah, that is.
Whole
interesting.
experience. 'Cause we are monitoring and we're looking at utilization and satisfaction, and so we'll bring it.
So there is a couple of high points I know that Lila went over that the committee made. I mean, you're in the call center, the abandonment rates went down. There are certain key things, and I know that Sally was concerned with that at one time. So there are certain pieces that maybe you should quickly go through.
Yeah, that's-
Valencia, just one quick thing before, in this past year, 120,177 people logged into the portal.
Just so I know that we're shorter on time. Sally, just really proud of the call center and the amazing work that they continue to do. You'll see the purple line, that our abandonment rate has been incredible. 1.7% in April, but consistently below 5% throughout all 2025. We start to see that come down in the middle of 2024, and we've been consistently below. So great job on the staff.
And that's like similar numbers.
Yeah, well, the call, if you go to the slide, previously, prior slide, the number of call volume, and our staffing has adjusted, but the call volume has gone down slightly in 2025, and this is all due to first call resolution, increasing for first call resolution, self-service, operational efficiencies that members don't have to call anymore. So all of that also contributed to a lower call volume, but then also a lower abandonment rate. So a very positive experience.
It's all interconnected,
Yeah.
right? We do a better job addressing the needs, sending the cards, giving them choice on PC. It's doing everything correctly. Ultimately, you know, it results in lower volume.
Go to the provider slide.
Sorry,
Just really-
abandonment means like
The members are hanging up because they're tired of waiting for us.
So do you track how long they're waiting?
Yes.
Yeah, and is that going down? Is there a correlation?
Yeah,
between
so we try to pick up the majority within 30 seconds.
30 seconds?
30 seconds to pick up the majority within 30 seconds, and then there's another time span. So we try to keep it in the lower half. And so right now, we had abandonment rates in the high teens, low 20s, and then we were able to steadily bring them down, and so we're hitting constantly below 5%, which is where we want to be.
Great.
On the provider side as well, if you go to the next slide, Angela. We did a couple of different operational efficiencies as well. Our goal is to hit 10% or below on the provider abandonment line, and we made a lot of efforts there, and we're at 5.8% for October. So really great work on the provider call center side as well. So Angela, could go to the next slide. On the NPS scores, we see that we consistently have an uptick with April being our highest at 64, but we do remain in the low 60s. And so that, again, I think that call center is working really hard and is a good indication of where we are as we do Medicaid tax season right now.
Brenda, can you give context? Because I think if you don't know NPS 61, so you're like, what is it? Can you provide the context?
Just from a trend line perspective, you can see that we've gone up spectacularly. This is a mix of both Medicaid and Medicare. This is our highest in the organization actually comes from medical management around 67. And to get to 61 at the type of internal volumes we have from the call center is exceptional. So I think I echo your sentiment, Lila. And in fact, it's compared to other industries, this is, we should be very proud of ourselves. This is at a level almost beating Apple.
Yeah, that's what I wanted you to clarify, because like you look at the numbers like, oh, 61 out of 100 out of, this is incredible. This is really incredible. Certainly unheard of in healthcare, but even in other industries that are much more kind of experience oriented, we're up there.
NPS stands for
Net Promoter Score. So the question we ask, which is an indicator of advocacy, is would you refer this company to your friends or family? And when they say 9 or 10, you're an automatic promoter. Anything below up to 6 is a passive, great, you're sitting on the fence. But anything below 6, you're an active detractor. You're going to tell people not to go there. So our goal is to always get as many, of course, people to be promoters, because that helps us grow our brand.
Great. And you'll also see in April, May of 2024, that's when we partnered with a vendor to help with the call volume, and we started to see the abandon rate go down. And so you'll see it through the end of 24 into 2025 as well.
And not to go into sentiment, but just one point overall, if you look at the slides, we are at the lowest ever rate of considering leaving the plan that we've ever been as a company since we started measuring. So we're at about 6% considering leaving the plan. We used to be hovering around 11 or 12%. So even if Net Promoter Score kind of stabilizes or goes down slightly, if members are secure enough in us wanting to still stay, that says something. So that's why we measure multiple things to help us indicate how we're doing with retention.
Right. Okay, that was all the good news that I wanted to share with you. So now you can move on.
So member complaints, just to give you context, for third quarter 2025, we received 170,000 calls, of which 0.6% led to a complaint, or related to a complaint. Overall, from 3Q 2025 to 2Q 2025, we went up by 11%. But when you measure 3Q 25 to 3Q 24, we're still lower than before. The three drivers are balance billing, where members should complain that they've incorrectly received a bill for services. The second one is MCO vendor complaint, mostly due to an ID card system error that was happening, but we were able to address it. So we go to the next slide. The balance billing complaints, the top drivers were related to 5 providers. And just to give you context, Carla, every balance billing is typically a top driver of complaints. Members are getting balance billing. It's typical. Last quarter, CityMD had a problem. There were different providers that were having problems with billing and so forth. But this particular quarter, we noticed that 5 providers were the reason why we saw an uptick. So it doubled. So in second quarter, these same 5 providers had 51 complaints related. In third quarter, it was 119. So it doubled. And related to system issues that they've had in various situations. And I'm not going to get into a level of detail, but One had a delay in posting their claims, and so it caused member abrasions. They were calling us about that. There was another provider that had an issue with billing for call share and shouldn't have been done. So our provider network operations team or provider relations team works with those providers and tries to call them, correct the issue, and we monitor it. So we're anticipating this to go down.
Can I ask a quick question? And I'm sorry if this seems not smart. We're talking about providers who have issues in terms of getting paid. We're not talking about.
No,
members.
we're talking about providers
Yes.
incorrectly billing our members.
It is the
Right.
members.
The members,
It is
the
the members. So here's my next question. Again, members who have Medicaid, are there some of them who are paying on, like, who are not fully covered for their care?
No, they're fully covered, but
Right.
sometimes our provider would push in a system, a new system, launch a new system, and will cause them to inappropriately bill some of our members.
I see. But in
That's across all
general,
products.
like you're a Medicaid Metro Plus member, you're not getting a member, you're not getting a bill. You have Medicaid, right?
Mhm.
Okay, so sometimes they're getting a bill and they're like, what is this?
Yes.
Right, I have Medicaid.
Yes.
Cool, thank you.
Okay, no problem. In terms of the total volume of complaints substantiated versus unsubstantiated, meaning the complaint was warranted after investigation. Angela, if you go to the next slide. 77% of the complaints received in third quarter was substantiated. If you go to the next slide. The top reasons for providers are calling us is consistent throughout every single quarter. It's usually about claim status, inquiry authorization, provider benefit inquiries. Yes, this is provider call center, sorry, but I should clarify that. These are our top reasons why providers are calling us. And 95% of all of our calls coming into the provider call center are related to these top 10 categories. To go to the next slide. And then from our joint operating committees, we have our provider network operations team or provider relations team has joint operating committees with select providers, actually quite a few, and a lot of our major systems. And from those meetings, these 6 or 7 top drivers come out of those meetings as the areas that we need to work on, and we have been working on them. One of them being the claim denials and underpayments. So we have been working with our configuration team to minimize the number of errors that are coming in through configuration. There is a peer review that has been implemented to make sure that our contract configuration is done accurately. Our providers receive an ERA, and within the ERA, which is your electronic remittance advice, there are specific codes with descriptions, and then our providers are able to reconcile their payment, what those codes are. Some of the codes were missing descriptions, and so that was causing some abrasions because they could not reconcile their books and payments. And then some of the other ones are more process improvements that were related to letters not getting to the correct places, and so we corrected that. So if you want to go to the next slide.
Well, that provider department.
Yes, we did.
Substantial.
Yes, we did.
And out of that arose a more aggressive way of monitoring complaints and providing provider assistance.
Yes. So previously, a few years ago, the provider relations team was broken up by territory. So we had provider relations focused in Brooklyn, Staten Island, and so forth. And what we did was we went through a reorg, and instead we have our provider relations team broken up by provider segment. So we have ancillary providers, we have the systems, we have somebody dedicated to the H&H system. So now when we identify that there's an issue, we're able to see across the systems the issue being prevalent and being able to cure it top down in a broader way. So that's been very helpful. You could go to claims. Claims has been doing a tremendous amount of improvements as well. Very proud of that team. To date, we had processed about 8.3 million claims, which is an 11.1% increase from over the same 10-month period from January through October 2024 to January, October 2025. And then our average denial percentage is 10%. If you go down to the next slide, we have our turnaround time in terms of processing claims, meaning that our providers are getting paid faster. In terms of our providers getting paid within 30 days, we are averaging at 97.17%, which is phenomenal. When I started to take over the claim operations, my goal was to get them to hit 95% because we were hovering at the higher 80s or lower 90s. And so we were the leadership team there has been doing a tremendous amount of work to hit a 97.17% for all of 2025, and then within 15 days, 91.21. And I think this does also contribute to a lower call volume because we are paying claims faster. So this has been a really great provider.
And this is on the old clunky system that we have.
Yes, so we were able to increase our adjudication and just do a lot of tremendous work. If you go to the next slide. From customer success, this is more member retention. This specific slide talks about recertification. You'll see the green line. We have been doing phenomenally well, especially when you hit June of 2024 all the way through around April of 2025, we're able to hit above 82%. At some points hitting 85%. And then in end of April of 2025, May 2025, the ending of the PHE unwind occurred. And with that, members who were automatically renewed were no longer being automatically renewed. We knew that. We knew that there would be a couple of hundred members each month being impacted, and we had a strategy to resolve that. However, what we found out was that a certain population, the SSI population, that were auto-renewed pre-COVID were also no longer being auto-renewed. And so we're working with HRA to understand that pocket of individuals. So you'll see from May through October, there are certain headwinds that we have been working with HRA and others in terms of the HRA auto extension policy, the SSI population no longer being auto-renewed, apprehension of the immigrant population, and then more recently, HRA they're transforming their own systems and moving into a new system platform as well, and there's a backlog that's been created. So we have been working very closely with HRA. I'm hoping that we will see this make an upward trend, probably around October to November. What we found to be interesting was that between the periods of April through August, we had about 3,400 members that disenrolled that were part of the SSI population. When we ran these members through ePaces, we found that 91% are no longer qualified for Medicaid. So these individuals were automatically being renewed. What we're finding out is that since they're no longer being auto-renewed, they probably didn't qualify for Medicaid, and that's where we're seeing the SSI population shrinking across the board, across the market. So we're keeping a close eye on that. If you go to the next slide.
I'll just say we beat our forecast by a lot, almost on every single lane, and significantly. The one important measurement where we're behind our forecast is on the membership.
We're back to 687 as of yesterday.
Yes, but I right before this meeting, I asked Lauren to look at our forecast of where we expected the membership to be at the end of 2025, and we missed our forecast, our target by 2%. So part of it, a big part of it, is not things that we can control, but nevertheless, that's the one measure that, regardless of whether they're objective headwinds, that we're not where we wanted to be.
From a disenrollment standpoint, overall retention, when we compare where we are for 2024 to 2025, in 2024, we were able to mitigate 4.65% of the members who were going to disenroll. We were able to save them, and they remain on the plan for 90 days post their disenrollment. So to give you context here, we had about 299,000 members in 2024 that were to disenroll. We were able to mitigate 14,000 members from disenrolling. When we look at 2025, we were were able to increase that effort to 10.24%. Where in 2025, we were to date, we were at 204,000 members that were to disenroll, but the actual disenroll was 183. So the customer success team looks at certain triggers or drivers of disenrollment, and we work with the members to assist them to prevent them from disenrolling. So if you go to the next slide, you'll see what our overall disenrollment rate is. And I know, Valencia, this is something that you're curious about. What we're looking at is in 2024, we had a 3.27% overall disenrollment rate, and in 2025, we're at 2.6% disenrollment rate. And you'll see that the involuntary disenrollments were obviously higher than the voluntary. So if you go to the next slide, is that it? Yes, that's it. Any questions before we go to the next slide?
Just the saves are from voluntary disenrollments?
Both. So it's involuntary and voluntary. And we have a better success rate with involuntary disenrollments. And so if you call, I've done these presentations where there's top 5 drivers of involuntary disenrollments unrelated to recertification. So it could be documents that are needed, COB, premium payments, invalid addresses, a lot of other drivers that could lead to a disenrollments. And we focus the team to prevent those disenrollments from happening.
Thank you.
Sure.
From my perspective, the most challenging part of this is not having benchmarks. So we obviously look at market share. So market share is a good proxy on how we're doing in the combination of acquisition and retention, but we don't have regular market share numbers for Essential Plan. We don't have it from, I mean, it's not timely. So, you know, we can compare ourselves to ourselves and how we're doing over time. And obviously we're doing better, but how are we doing compared to our competitors is something that continues to be a bit of a challenge.
That's not information that the state provides.
No, I asked analytics to go and look.
Yes.
They were providing, when the unwind just started, they actually were providing the information. It was so helpful because we could see where we were, and we were in the middle of the pack when the unwind just happened. It was the first time we could actually track month by month how we're doing, but we don't have
That was
it.
specific to recertification. We were able to track, but not total disenrollment. Yeah.
They
I
put
mean,
out
part
a,
of the issue, I just wanted to state that you do enroll each month. There are enrollments happening, but they're mitigated by the disenrollment.
Right.
And it sort of keeps you stagnant almost at
Right.
the same pace. And so the goal, as Lila has indicated, is to reduce the disenrollment.
Yeah.
Right. I mean,
Especially-
it's both sides, right? Because I'm always looking at Roger of how are we doing in terms of new acquisition, although he's also doing retention, right? Because of the dashboards. But you know, we're looking to see, are we doing well on acquisition? Are we doing well on retention? And because there are objective headwinds, you know, it's important for us to understand how we're doing compared to others, right? Because if something changes at the state level, right?
Everybody would be.
Right, but I want to see that that's in fact the case, and it's not easily accessible.
Yeah, and we're being very purposeful with how we go about addressing the disenrollments. And so I do see us maturing the program more as we go through this in terms of putting more solid benchmarks and, you know, voluntary disenrollment, identifying a benchmark on that could be more challenging, but we're going to continue to raise the bar and try to increase our retention. I do think that our retention for 2025 has been good, but we want to make sure that we continue to lower our disenrollment rate.
And remind me again, Brenda, at one time you were following up on disenrollments, right?
Mhm.
And your findings were most people were disenrolling because of network, right?
Yes, so I think
The voluntary.
the voluntary
Yeah,
disenrollments
yeah, yeah.
are because of network, yeah.
And
In dental, right? Dental complaints
Specifically on
and, you
EP
know.
was related to dental, which we've done work around that.
and there was an area, and I apologize, was it Queens that we were trying to focus on?
Mhm.
How are we doing in that area as far as the growth?
in certain zip codes better than others. So there's some target zip codes that network does play a factor into the growth in those areas. So we're working through it. Mhm.
For full transparency,
Mhm.
we're not where we want to be in Queens.
Open the Flushing office, right?
We have, but opening an office is not magic.
Yeah.
Right? It's opening the office and then using the office as the base to build all the relationships with the community, right? With the CBOs, with the community. You have to be proactive. And now you have a new base in the community, but you don't just sit and wait for people to come to you. You really have to be very proactive. In fact, we're between marketing and growth, we're talking about a very focused strategy for 2026 around Queens. And Valencia, you're bringing this up, of course, very appropriately, because we haven't seen the progress we wanted to see. We brought this up to the committee. We said we're struggling in Queens. We're not seeing the growth we want to see. Some areas, yes, and we're not seeing the retention we want to see. Again, it's not uniform, but generally speaking. And so our strategy to date has not been effective. So we're pivoting into saying, okay, stop talking about Queens. It's a huge borough. It's very diverse. There's just a lot. It's not working, just talking about Queens, not even about specific zip codes. At some point we said, okay, let's focus on specific zip codes. It worked in acquisition. We had some increase in acquisition in some of the zip codes that we identified, but the retention in Queens continues to be an issue. So the new approach for 2026 is really to identify clear providers who want to grow with us, make sure we have the reps that are well fitted into the attachment area that those providers that we identified as partners are operating in. And let's just focus on something very narrow, very concrete: provider, reps, network, and see if that will be a winning formula. So far, I don't think we have a winning formula in Queens.
So, and it's still primarily the network that kills us in Queens.
So I use it. You brought up Flushing, right? Flushing is in the Chinese area. Where our community office, it's a big commuter area, not making any excuses. So you got people coming from College Park and all these different areas. And we do see increases outside of the Flushing zip code itself that's supporting, because they're commuting through there and we're picking them up. Kuiper plays a big, a major part of that area around Flushing and all those supporting areas. And the main hospital they use in Queens is not in our network. So there's a couple of dynamics.
Presby,
yeah. So Kuiper's in our network. Our membership in Kuiper just remains flat. They've told us to our face a number of times about not having those hospitals. And so being in Flushing, even though we have the Kuiper doctors, if the member chooses a doctor but gets specialty care or inpatient care, and we don't have the hospital, they don't stay with us.
But there is hope.
Yeah.
There is hope. And the reason is, besides kind of more effective partnerships with large groups and less effective partnerships, the hope is systems that are in our network opening more and more locations in Queens.
Mm-hmm.
And so not having Presby in our network is becoming less and less of an impediment.
Mm-hmm.
So we need to leverage the fact that the other reputable systems are now having a more significant footprint. We have to identify, a collaborative provider group, which we have. And so now
they're on the network, or
they are, and they are also in a risk arrangement with us.
Mm-hmm.
So we think that will be a more winning strategy. You've seen this, you've seen before, right? Even with the call center, it sometimes takes a few turns until we get to the right solution. We haven't gotten there yet, but I think this new strategy around Queens might be the right solution.
It's almost inverting.
Yes.
One after the provider and then the members versus the members. And
yes.
Not having
yes.
So that might work.
Okay. I have my last slide, or are we good?
Up to Valencia.
Yes, go ahead.
Oh, okay, if you wanna go to, just really quick, in terms of Project Edge, Tomas had alluded to, the business areas, working on developing policy procedures and desktop procedures. So we partnered with a vendor called Compass Health, and one of the important criteria was to ensure that the vendor had managed care background so that they could understand managed care lingo and quickly create the operational assets of policy procedures, who, what, when, how, and then the desktop level procedures, which our employees would use. We onboarded the team back in February of 2025. And they have been looking at all of our policy procedures. At that time, it's 475 policy procedures, and we identified 158 that actually needs to be enhanced. If you go to the next slide. This is the team that we brought in from Compass Health. The blue boxes, Joe, David, and Ann, we broke it up between the claims, provider network, enrollment, billing, all the functional areas. Was one team. Then we had analysts and compliance in the middle team, and then we had medical management on the far right. And they worked closely with all of our functional areas. It was a great team that really worked hard. And if you go to the next slide, just so that you can see what the breakdown and the outcome was, we worked on 533 total operational assets and counting. We are seeing this increase as we get closer to go live. We are continuing to identify desktop level procedures that need to be built out. But 158 corporate policy procedures were modified. You'll see the departments that were impacted. On the clinical side, 152 DLPs were created. And then from the operational side, 223, and that number continues to count. So the amount of work that went in was just surmountable. Compass Health will be rolling out in 2 weeks, 2 or 3 weeks at the end of the year. If you go to the next slide, and all the policy procedures and the operational assets that were created, these were workflows, all the things that help and will assist the business areas to succeed in guiding care and HRP will now be housed in Scribe. And so it would be view only with certain modification access being provided. And so it will be centralized into this platform. So really excited. The teams worked really, really hard doing business requirements and now creating these policy procedures so that everyone's successful come Monday to go live.
I guess I just forgot this one. These are policies and procedures that are going to make Project Edge work better?
It's our policy procedures are right now catered to our current system. And so we need to enhance wherever needed. For policy procedures, we made them system agnostic. The DLPs, the desktop level procedures, kind of create new ones because it's a brand new system, enhanced workflows, everything had to be redone. And so we worked with all the divisions to make that happen.
It's essentially the way you buy something, right? And it comes with instructions.
Yeah.
So we have a new system, it needs instructions.
Everything changed, yes, and so it's a lot of work is involved here.
So the one question that I was thinking about, which, and I hate to even say this out loud because it might happen, but in the policies and procedures that you had developed, I know the state does their audits and whatnot, and they sign off on your policies and procedures. Did you ensure that some of those components were carried over, of course, and so that the state won't come back and look at them and be like, this changed and what happened and now it's wrong?
Policy procedures, we made it, because those are the policy procedures of what the state will review, we made it system agnostic so that it could fall into any audit, and regardless of whether we change the system or not, the policy procedures can stand on its own.
Okay.
The DLP, which is under the hood, that's system specific. And so we created all the new DLPs to support the policy procedures. They went through an approval process too. Everything went through an approval process.
Just to add a lens to it, we have a process in place to update, review, and sign off all of our PNPs every year. When we went through that process this year, of course, bringing compliance in, we took an opportunity to decouple some of the desk level procedure components from our policies. So what we took together with our business partners and compliance partners through our policy and procedure review this year is our new golden standard for how we do this. We had to redo it to decouple it from the system pieces anyway, and we took advantage of the do it right.
Next. That's it. Okay. That's good.
Thank you.
Thank you so much.
Great work.
Unbelievable.
Yeah, amazing
Unbelievable.
work.
Team
Congrats.
does do a lot of good work. All of your teams do a lot of work. I
Okay.
get tired just listening to it.
Me too.
Great. Thank you, everybody.
Thank you.
Most amazing how they work together, right?
Yes.
The system, to the policies, to the training,